some advanced interventional pain therapies that we can do for most commonly for chronic back pain, although there are some other diagnoses that we will treat as well. But just kind of getting into it, tonight's plan is basically talk about kind of different options that we offer for different kinds of chronic pain, see what options may work best for specifically for your personal pain, and suggest things to bring up to your doctor, or if you currently have, if you see a spine doctor, to things to talk with them about as well. So first, it's important that we understand that there are different types of pain. There's mechanical or neuropathic, and I'll often like to add myofascial. So if I'm rubbish with this, so if anyone can't hear me, unless you need it for videotaping.
Well, in case somebody's hard of hearing.
Okay. If anyone has any difficulties hearing me, just let me know, okay? I'll try to project as much as I can, just because this is going to be probably more distracting than anything else. Okay. So, like I said, based on like mechanical, nociceptive, and I'll add a third one in there, and we call that myofascial pain. And so basically each one of these different 3 categories of pain has a different source, has a different symptom that will be brought on by different situations, different movements, and some can occur with or without an exacerbating trigger. Some can accompany weakness, numbness, tingling, what we call paresthesias, that pins and needles, like I fell asleep on, my foot fell asleep kind of, and now I started walking, that kind of feeling. And then also shooting, burning, and stabbing type pains. So one of the measures that we look at in chronic pain, not just the classical when you go to your doctor, or even my young children when they go to their pediatrician, they have that smiley face scale, 1 to 10, sad crying face to happy face, and where do you fit on that 1 to 10 scale as far as your pain? But we generally in pain management, we want to go a little bit more than that, right? Not just what's your 1 to 10, right? We want to know what kinds of things does your pain prevent you from doing, right? In order to live a full, functional, and enjoyable life, right? We call quality of life measures, right? So that's things like being able to perform basic tasks around your house, cooking, cleaning, caring for yourself, right? Caring for others that may live in your house that depend on you. The ability to work and be productive, right? Playing with children, grandchildren. Actually, my mother's coming to town tomorrow from California to see my her granddaughters, right, for the next week. Sexual activity, other kinds of quality of life, hobbies, gardening, arts, crafts, things like that. Outdoor activities, walking. All of these things are things that people want to do. And that may or may not be affected by their pain and their quality of current pain control. So there are lots of different treatment options. Some are available with a chronic pain specialist, a spine specialist, a primary care doctor may employ some of these different treatments. So most classically for nociceptive or arthritis-related pain, right, or inflammatory pain, that'd be NSAIDs, your ibuprofens, your Aleve, your naproxens, meloxicam, Mobic. These are non-steroidal anti-inflammatory drugs. So the name says it all right there. Anti-inflammatory, they treat inflammation, right? Certain type of pain, right? So again, going back to that, to me, it's very important. This is what I talk to my patients all the time about the 3 different types of pain. And why that's important is because each one has a different treatment, right? So physical therapy, right? So that's at a physical therapy center, right? So that is to treat myofascial pain, which is one of the ones that was not listed, but it's a different pain. It's a muscular pain, and one of the basically best treatments for that is physical therapy. TENS unit is another thing often employed. It used to be probably 10, 15 years ago, more commonly prescribed by the doctors, but it's much more harder to get now with insurance. So mostly it's employed at physical therapies in their offices as part of their adjunctive treatments. Opioids, right? A very common buzzword that we hear now, but a commonly prescribed medication that works on the way the nerves transmit pain information. So like we've talked about, some of these things work on specific things. Opioids will work to block or reduce the pain signal that comes from all three. So they will work for all different three, right? But they don't treat the underlying cause, right? And the way I usually talk about pain is a three-step process, basically, that there's an initial problem, whether it's degenerative joint disease, age-related degenerative joint disease in the knee, or I've had back surgery, or I have diabetic peripheral neuropathy. That causes nerve pain. The arthritis causes, the inflammation from degenerative joint disease of the knees, muscular spasms in the back. That causes the pain, right? So the opioids treat the pain, they don't treat the problem that generates the pain, right? So then going more advanced kind of things, there's implanted opioid delivery devices, which we call intrathecal pumps, very more in vogue about 10 to 15 years ago, less in vogue now. There's lots of issues for that. And then surgical intervention with different kinds of spine surgeries and those types of things. And then certain things that we'll do in pain management, and also the surgeons may do nerve blocks, which can be used to treat pinched nerves or arthritis, those kinds of things. So lots of different kinds of, from just basic leaves to more advanced, of course. So there's a couple options that I'm here today to talk about specifically, and that's kind of a little bit further, it's not further, it's a little bit newer than some of the other therapies that we had mentioned. So the first, radiofrequency ablation, which is basically using very high frequency radio frequency to cause some thermal lesioning of very small nerves that sense arthritis. And that's a way that we can treat arthritis-related pain without resorting to NSAIDs. And then another one that we'll talk about is something called the spinal cord stimulator, which is something that is a device that targets the nerves in the spine that transmit pain signals from an area of the body, regardless of what type of pain it is, right? Like I mentioned, all three different types of pain. All of those pain signals have to go through the spinal cord in order for us to feel it, right? If I feel something, it has to go through a nerve. That nerve travels through the spinal cord, and that's how you feel things. And so the spinal cord stimulator targets those nerves as they travel up the spine to the brain in order to adjust, change that frequency of pain information and help with pain control. So let's talk about what we call RFA, or radiofrequency ablation. A lot of people will say, oh, I had my nerves burnt, or the doctor did some nerve blocks to see if I would be a candidate for this other procedure. This is what they're talking about. Basically, it's a very small area of heat that's generated over the small nerve that feels arthritis. We'll do this to block. So if you have arthritis in your knee, that pain information is being felt, that wear and tear of the cartilage, that inflammation of that arthritis is being felt by small nerves. And then again, if you feel something, it has to go through a nerve. So that arthritis or inflammation in the knee goes through the nerves in the leg to the spine to your brain. And what you can do is do an ablation for those nerves here. Also for arthritis in the back or neck, you can do what we call radiofrequency ablation. Like we talked about over here, or no, I didn't talk about it, but there you go. You can do radiofrequency ablation for arthritis in the back, in the neck, in the hips, and in the knees. Any joint that you have, and probably in the next 10 years, I'll probably do elbows. I've done ablations for shoulders, that kind of thing. Any joint that has arthritis, again, same kind of idea, it has to go through a nerve, and that nerve can have an ablation in theory. So it's a minimally invasive outpatient procedure. It is, if you've had steroid injections in the joints and they don't seem to work anymore, which is very common with knee cortisone injections, and there's data to show that that's not good long-term anyway. Medications like NSAIDs or those kinds of things. And so the way we do this procedure is basically, it's very simple. We find the joint, we put some numbing medicine over the joint, over that little nerve, and that's it, go home. And if you get better, it's only gonna be temporary because it's just numbing medicine. Like at the dentist, your teeth your mouth may be numb a little bit for a couple hours. But if someone goes home after I do a nerve block to see if they're a candidate for a radiofrequency ablation, they'll say, oh, gee whiz, my pain for that 3 days in my back or my knee was 60%, 80%, 100% better. And then the medicine wears off and they're like, oh, it came right back. So that, if that somebody tells you that, then you say, oh, well, whatever that number they gave you, if it's 30%, 60%, 80%, that's how much pain was coming from that area. That's very important for the back, right? Because in the back, you can have muscular pain and you can have arthritis, and it's hard to tell how much is what. So if you do a nerve block on the joints in the back that have arthritis, and somebody comes back and says, oh, gee whiz, for that 2 days, I was at 80% pain relief, you say, well, 80% of your pain is coming from arthritis. And if they, vice versa, if they come in and say 20% of my pain relief, right? Then you say, well, 20% is coming from arthritis, probably the other percent is 80%. But if somebody gets over 80% pain relief, that's a lot, right? That's a home run for anybody that has pain. And so if you get 80% pain relief, then what we can do is a radiofrequency ablation, zap that little nerve. They'll regrow, but it takes about 6 to 9 months. So if you can get somebody close to 80% pain relief for 6 to 9 months with a procedure that takes 20 minutes, again, that's pretty good, pretty good relief, right? And this is not, again, non-surgical, injection-based, right? So another thing, so the kind of the main reason, the reason for the season, right, that I'm talking about, right, is the spinal cord stimulator, right? These have been around for a long time, 20, 30 years. To me personally, probably about 6 or 7 years ago, they've got dramatically better, right? They used to, I think, be reserved for like the worst of the worst. Now they're becoming more and more common, and the results are becoming better and better. And so let's talk about it a little bit. So basically, what kinds of things do we treat with spinal cord stimulation, right? So neuropathy in the feet and legs, either from diabetes, from ischemia, like peripheral vascular disease, complex regional pain syndrome, something that we used to call RSD, which is kind of a nerve, kind of hyperactivity problem, a phantom limb pain, so again, going next door to it is your neuropathy, CRPS, complex regional pain syndrome, or reflex sympathetic dystrophy is another word for it. Another very common, probably the most common indication that we do at Murray Regional, which is, don't tell the surgeons, failed back surgery syndrome, but they don't like to call it that because technically their surgery went fine, but the problem is either the patient didn't get better or eventually got worse or had some issue during the surgery from scar tissue or what have you, and now they have some other pain. Years ago, 10, 15, 20 years ago, the surgeons used to just keep doing more surgery, right? I think the record for me I've seen is a patient who had 12, right? And I thought, well, gee whiz, after 5 or 6 or 7 or 8, why wouldn't you stop? And I don't know, it's very many reasons, but 12 back surgery, still no better, right? So that's probably now we call it post-limb right? There's a role for surgery, don't get me wrong, I don't want to come off as anti-surgeon, right? There are lots of good surgeons doing very good work, but back pain and back surgery is not a A plus B equals C kind of thing. There's lots of different things. Like we talked about 3 different types of pain. There's lots of different things that the surgeons can address, and some of them that are harder for them to address. And so other things, so what things that we look for, people have to take pain medications, they have average pain scores 5 or 10 or higher, have significant limitations, like I said. I mean, we don't always, oh, what's your pain? 8, okay, well, you should do this. It's more of a kind of a whole patient kind of idea. And so other folks, again, if you've been in chronic pain for at least 6 months, it's not, I was lifting a piano with my cousin and I hurt my back and now I'm gonna get this device put in my back. It's long-term symptoms, having multiple different things tried and not working. Again, like I said, you wanna make sure that if we can send somebody to physical therapy and get their back pain tolerable, that's what we wanna do, right? Because that's a treatment for their actual pain generator, which is myofascial pain, right? Again, epidural is steroid injections for pinched nerves, radiofrequency ablation for arthritis. And we want to look for specific targets for pain. So even though it says back, legs, and feet, neck, pain that shoots down the arms, pain in the middle or lower back. Again, I mean, generally most targets, you should be able to, in theory, target anything with spinal cord stimulation, although there are some consistent things that we look for higher chances of success, but there's lots of targets that you can think about with spinal cord stimulation. And then, like I said, so spinal cord stimulator therapy, we consider it when patients don't want to take opioid medications, right? They go see a surgeon and the surgeon doesn't offer them back surgery, right? I had a guy who was 79 came into my office and I saw a surgeon, he said, I don't operate on 80-year-olds. As I was saying, I don't operate, by the time I do your surgery, you're gonna be 80 and I don't operate on 80-year-olds, right? Because he was 79, right? Or for other medical problems, a lot of time what happens is somebody has multiple areas of their back that have issues, and the surgeon says, well, it's not just one level that I would have to put hardware in, it's a lot of them. And that's a really big surgery that could take 12 hours and it would just be too risky, right? And so even though if somebody could have surgery, they would, and so then they're out of options and they come to me and we talk about a stimulator and they get good benefit. Let's move forward. So again, talking about spinal cord stimulator, like I said, it's been around for a long time. FDA approved for multiple issues, most common of which is that post-laminectomy, post-surgical back pain, although every year that FDA approval is changing, pushing the indication for people that haven't had back surgery, have all sorts of different problems, is something, like I said, it's something to consider. And generally for insurance companies, as long as I demonstrate that the patient has tried and has done everything possible to treat whatever their main issue is, that it's something reasonable to look into. Sometimes it's an uphill battle, sometimes it's not. Again, it's reversible, it can be removed. There's a temporary trial, and we'll talk about that in a little bit. So hopefully the goal of everything that I do, especially here in Middle Tennessee, where we've had a large opioid problem for many years, my job is to, when folks have to take opioids, my job is to figure out why and then come up with a treatment for that, right? And so I don't use opioid reduction as a marker for success. I use patients getting better as my marker for success. And almost, I would say every one of my patients does not want to have to take, if they are on opioids, they do not want to have to take them, right? So if I can help them with their pain, most every single person does not want to have to take these kinds of medications, right? So if I can help them with their pain, they're more than happy to come off those medications. So like I said, FDA approval, with the right indication, we'll get approved for the insurance on the issue. And again, last 5 or 6 years, and every couple of years, it's just things are getting better and better and better with the technology, and that technology advancement leads to better patient outcomes. So how does it work? I don't know if this is gonna work. This little video. Nope. What was it?
Are you linked? Are you on the internet?
I think it's because I'm not on the internet, but I think if you just talk through the trial and then.
Yeah, okay, sure, no problem. So basically, is that better? Okay, so basically the way spinal cord stimulation works, and this is verbatim what I tell patients, right? The way our body works is, and usually I'm sitting down, so if I do this, right, me doing that makes an electrical current, right, that gets transmitted through a sensory nerve in my leg. That electrical impulse takes that information to my spinal cord, and all roads lead to Rome, right? So all of that sensory information goes up the spinal cord to your brain. And that's your brain's a computer that takes that sensory information and computes it, right? It says you just patted on your leg, right? So the beauty of spinal cord stimulation is that it does not matter what the problem is. If you feel it, right, it is going through that pathway, right? So the difference here is like I said, there's different kinds of pain, right? So if I do physical therapy, I'm treating myofascial pain. If I do an epidural steroid injection, I'm treating a nerve that's being pinched. If I'm doing a radiofrequency ablation or a joint injection, I'm treating arthritis. All of those things have to send sensory information through nerves through the spinal cord. So what the spinal cord stimulator does is basically at the level of the spine, using electrical impulse or wavelength, targets the nerves in the spine, right? And kind of like a game of telephone, blocks or reduces that pain signal. Either changes it, right? You know, that my telephone analogy is rapidly gonna be dating me, right? But it's, you know, you can either change the information, right? Change that pain information from painful stimulus to a vibration or a tingle sensation, or you can block or reduce that pain signal and you won't feel anything per se, but just block or reduce that pain, right? Using it at the level of the spine, right? And so how that's done, right, is basically there are two parts to this procedure, and really this is why I'm a very big proponent of it, as opposed to other things that we do or surgery, is there's two parts. There's a temporary one and a permanent one, right? The temporary trial is a 5-day temporary trial that's put in non-surgically, generally either in the office or with some mild sedation like a colonoscopy. It's 2 needle pokes, basically, right? So you know how women get epidurals for childbirth, right? So I'm an anesthesiologist, I've done plenty of those. You sit the woman up on the bed, you feel on their back, you put a catheter in their back to give them numbing medicine, right? Very similar to that procedure, mixed with some of the injections that we do for pain, which are under x-ray guidance, right? So under x-ray guidance, basically for most, so let's say for patients that have low back pain or leg pain, basically at the top of the low back, under some mild anesthesia, check with an x-ray, a couple of numbing injections, and then 2 needles go in between the bones and the spine into that epidural space. And we put 2 temporary leads in, right? Once we have them in the right position, we wake the patient up from the anesthesia. Then one of the folks from Boston Scientific or you know, another manufacturer will ask the patient, you know, where do you feel this when we turn it on? And we make sure that we're in the right position that should cover where your pain's at. All that checks out, needles come out, a couple anchors, get a couple stitches, and a whole bunch of tape. You have a temporary battery pack on a belt, and you got a remote, turn it on, turn it off, turn it up, turn it down, depending on how your pain is. You go home with that for 3 to 7 days. My trials generally go 5 days. And on the 5th day, you come to my office and I take it out, right? That's it. If it worked well for you and you got at least 60% pain relief or more, you say, wow, that thing worked great. The permanent one is like that procedure I just discussed mixed with a pacemaker, right? So you know what a pacemaker is, right? So it's basically 2 small incisions, one here, one for a battery, leads go underneath the skin to the other incision. The temporary trial, depending on the person, depending on how what problem we're doing it for, can go from anywhere from 20 minutes to an hour and a half, just depending on all sorts of different factors. The permanent one probably adds about 45 minutes to that, so about an hour to, you know, an hour and a half, 2 hours, okay? And that's the procedure. So there are 2 different types of batteries for the permanent one. There's a rechargeable one that most patients will recharge once a week for about 45 minutes, wirelessly through the skin, with a little kind of charger that you place over the battery. Then there's a non-rechargeable one that has to be replaced every 2 to 3 years. I usually tell folks probably 7 to 10 years to replace the batteries if it's a rechargeable one. I've been doing this for 6 years now. Haven't had to change a battery for not functioning yet. So I replaced one from 15 years ago that someone else had put in, and the device was working fine. It just stopped charging and she needed a battery. I think she was 89. So that is basically how spinal cord stimulation works. I don't know what
Is it working? Yeah.
Okay, we'll just hope this was the very next one. So basically, how do you know if the trial worked for you, kind of like we talked about it. I mean, I think, of course, for me, and because the insurance kind of says, really want it to be at least 50 to 60% pain relief in order to be qualified as a success on the trial. But, again, like I said, that score is not what we base everything off of. It is, and this is what I tell folks, it is, I haven't been able to walk in the afternoons with my husband for the last 2 years. I haven't been able to even think about cooking Thanksgiving dinner. I haven't been able to go to Disneyland. I haven't been able to do those things. I haven't been able to go to Walmart without being erect the next day, or sitting in a buggy, or leaning over the cart, that kind of stuff. Those are the kinds of things that patients come in and tell me, that this is part of the reason why I'm being benefit. That's why I tell folks when we talk about pain medication. No one coming into my office giving me a hug or crying because I prescribed them pain medications or gave them an anti-inflammatory, right? And so being a physician, and certainly a chronic pain physician, the types of things that I can do to really help people live better lives, that's really where you become a doctor. And so spinal cord stimulator is one of the things in my world that I do that lets people do that. And so that's why I'm here talking about it, right? Because I'm a huge believer in it, and it's just not as common around here, and so the more we can get people to understand about it, the more then they go to their primary care doctor, or and they talk about it and have more options for treatment. So going back, so basically sleeping better, that's probably one of the first things that we'll hear, usually day 2 of the trial, people say, well, they're sleeping better. Usually by 72 hours of the trial, most patients will know if it's for them, and we'll talk a little bit more about that. I mean, it's fairly. So again, with spinal cord stimulator, like we talked about, there's 2 different modes, right? And so you can kind of target and customize what responds best for you. Sometimes patients say, oh, gee whiz, I had a TENS unit back in the day that I love that thing. I would be on that TENS unit, I loved it. So generally those patients really like that paresthesia or the kind of vibration or tingle sensation, right? Some people say, I hate my TENS unit, I hated that thing. So maybe paresthesia is not for them. But you get to kind of trial both of them, right? See which one you respond to. A lot of patients will use both. Some patients will use the no-feel ones at night, or some people like the paresthesia. It's just, you get to kind of basically try it and decide what you like and mold it to you. Also, some patients will say, well, gee whiz, at night my feet really bad, or my feet are really bad at night, but during the day my back's really bad, right? You can have different programming options for that. And again, really allowing you to kind of fine tune what you need out of the device. It's not just on, off, pain relief, no pain relief. You can kind of turn it up when your pain's really bad, right? So sometimes patient will have a paresthesia mode that let's say I went to the store, now my back's really bothering me, or I drove 4 hours and I got out of the car, it's really bad. Then you can turn on the paresthesia, kind of turn that intensity up, right? Because their pain intensity is up, and then turn it back down when things kind of ease up. So again, it allows you a little bit of flexibility there with how your therapy is being given to you. Again, lots of data here to show that there is benefit here. This is relatively new data from 2020. Basically a reduction in pain scores from 8.5 to less than 3, right? After 2 years of therapy, which is a huge amount, right? So again, apps, right, that can help you log. Some folks are more into this than others, but helps you kind of log how you're doing with your therapy and your days, and you can take that to the representative from the manufacturer who you can talk to and adjust your programming. That's another big thing, right, with certainly Boston Scientific, is that you can adjust the programming as you go, right? And so down the road, it's not unusual for 3 months down the road, well, gee whiz, yeah, this is working great, but it seems not to be hitting my left hip as much as I want it to be. And you can get some things adjusted there to maybe cover that a little bit better. or some of these information is, well, gee whiz, yeah, I'm doing really well during the day, but at night I'm not doing really well. And that, again, helps us understand what you need and adjust the therapy to what you are needing, right? So again, for me, we do quite a bit here of spinal cord stimulation. And again, I have personal reasons why I do that, and it's because out of the things that I do as a chronic pain physician, this is one of the things that really has changed people's lives. It sounds corny, but it is. Like I said, there's no medication I'm prescribing. Is people are coming in here with talking to me about the things that I'm able to help them achieve. And overwhelmingly have been very positive, right? My patients are my advertisement, right? Murray Regional does not advertise for me, right? My patients do, right? My patients go to their church. My patients tell their family members. One of the people that does the x-rays sent his dad to me for his a stimulator because he couldn't really walk after his back surgery. Those kinds of things, and so overwhelmingly successful. It's just getting better and better. And honestly, it is part of the reason why I'm here talking about this is because of the area where we live. I think if, as we move along, Middle Tennessee is slowly but surely getting more and more advanced medical care options for the patients in our area. And this is part of it. And so my job is to get out there and tell people, and and then the more we do, the more we do, because people will go tell their primary care doctor, they'll tell their neurologist, they'll tell their surgeons, and those patients will get, to see somebody, whether me or someone else, to get things like that we talked about tonight. Any questions about any of this?
Shoot. A couple.
Yeah.
If you're blocking the pain signal, are you also blocking other signals? Do you still have full sensory capacity?
Correct. Yes. And I've had patients say, well, I don't want to injure myself. It doesn't work. You're not Superman, right? So no, yes, you can still feel, you can still overdo it. Even with therapy, I've had patients say, oh, I really overdid it the other day, right? Because I was out, redoing my driveway or whatever. And so, yeah, you're still gonna, it's not, worst pain to zero pain, and now I'm, no, you'll still, if you overdo it, you may still have pain. You may have more pain than you did, but it's probably still gonna be less than it was without the stim.
You're an anesthesiologist
Sure.
by training. Orthopedic spine surgeons do back treatments.
Mm-hmm.
Interventional people do back treatments. Who's doing most of these spinal cord stimulators? Is it you guys? Are the orthopedic spine guys doing this also?
So there's a couple of neurosurgeons up at Vandy that do these. To be honest, the spine surgeons, there are lots of spine surgeons that do these, right? Most spine surgeons are busy enough doing spine surgery that they don't do this, right? You can also say, well, again, one of the diagnoses listed there was failed back surgery syndrome, right? So if this device was made to treat something that a surgeon could not treat or failed to treat or caused, maybe they might have some reservations about picking up some new thing, doing, not something new, but doing something that was made to treat the problems that they could. But honestly, I think it's just there's only so many hours in a day, and most of the surgeons are gonna do the things like the surgeries.
Well, yeah, that's what I'm thinking. There's a progression here.
Yeah.
You've had the injections, you've had
Correct.
physical therapy, you've had
Correct.
these other things, you had a foraminotomy, you had a discectomy, and these orthopedic spine guys, okay, what's next is a fusion.
Yeah.
And
And
that's not the case.
Well, it depends. So I have patients that come through and they get sent to me from a neurologist, and they have a bad back and they've never seen a spine surgeon. I said, well, go see a spine surgeon, right? Get that information. You don't have to have surgery, but if they can fix you with a back surgery, then they need to fix you with a back surgery. Because this doesn't fix the problem, right? It addresses the pain that comes from a problem. But the reason why we do this is because the treatments either don't exist or are not working, right? Or like I said, the patients have not been offered back surgery, right? Or the surgeon says, I cannot fix you with back surgery, and then they're stuck, right? So yes, I say, again, I see patients, and I just told one this afternoon, I see patients, new patients, every day that have had back surgery for the last couple of years. And I heard last month that there are more spine surgeons per capita in Middle Tennessee than anywhere else in the country, right? So there are spine surgeons every day in Nashville, in Spring Hill, Columbia, doing spine surgeries. Franklin, doing spine surgery every single day, and usually not just one, right? And so the chances are that that's gonna generate somebody that did not get a favorable response. And then this is the next step. Like I said, we've learned that, yes, correct. The progression goes, discectomy, laminectomy, fusion, right? And, and there's a place for that. But after they've had, I think, and that's what I said, after 3 tries, generally for me, the incrementally less and less success. Again, that's anecdotal. Don't go get me in trouble with any spine surgeon around. But again, my job is to treat the problems that they cannot fix or have not been able to, and that's okay. They have a role, and I am not saying that they're not doing their job correctly or there's not a role for them by any means. Yeah, there's a place for it, just like there's a place for neuromodulation or spinal cord stimulation. Any other questions? Yeah.
I understand the criteria and everything. But is there a process you need to go to your doctor and they refer them to you?
Yes.
They
Generally,
can't just call you and say,
well,
I want to consult, or
yeah. I mean, I think right now we're asking for our new patients for referral from a primary care doctor or another physician, either a neurologist, a surgeon, someone like that. Yeah, just to have that. I think it's necessary to get that referral. But that's the generally. So then, kind of like a surgeon sent me a patient who hadn't had back surgery, and I was a neurologist also, but hadn't had physical therapy, had no injections, had no other kinds of medications. And I said, listen, I would love to do this procedure for you, but ethically I need to do the things that I need to do, because the more people that don't do those things, then it just gets harder for everyone to get access to the procedure. Yeah.
I have a pacemaker and defibrillator.
Not an issue. And good data behind that. I've talked to the folks at Vandy about that. There's good studies out there that show there's not an issue with it. I actually have a trial coming up with a gentleman from the defibrillator. Generally, what we do is just have the device company, and Boston Scientific makes implanted cardiac devices.
I see.
Yeah, and so basically what I generally do is just have the representative from whatever device it is just meet with you after we do the procedure, before we turn it on, interrogate everything, turn it on, interrogate everything, just to make sure everything is okay. But again, there's good data out there, trials, 20, 40 patients, showing no changes at all with any of the device with stimulation.
I had back surgery in '82,
Mhm.
and same doctor operating on Phil, operating on me. And I've been to chiropractors. I've had a shot every 3 months
Mhm.
for a year.
Yep.
And had massages and all that, and it's just right in the middle of my back.
Yep.
Right there.
What we call axial back pain, or that's probably the most common thing I do this for, okay? Surgeons are very good at treating pain that shoots down the legs. It's harder for them to treat pain in the back. So oftentimes when people go to their back surgeon, they have pain in their back that shoots down their legs. They go to have their surgery, and then now they no longer have that back. Maybe it's just in general though. The leg pain's better, but the back pain persists.
Well, it doesn't go down my legs.
Yeah.
It's just in my back.
Yeah.
I bend over, get the dishes out of the dishwasher, or the clothes out of the dryer,
Mhm.
or try to pull weeds.
Yep.
Can't do it.
Yep. It's very common, very common. Like I said, that's probably, that's 80% of the patients I do these for, with just exactly what you said, right? It's just a very common problem, and surgery it's hard to fix that. So, the other questions before I turn it over. Carolina, yeah, go ahead.
How big is the device?
It is, I can pass this around. It's about like the size of an Oreo,
Okay.
right? A little bit, not a double stuff.
That's the other patient.
Not a double stuff. Probably, I mean, it depends on the device, but yeah, it's fairly thin, right? Most patients, unless they are like, 90 pounds soaking wet, right? I mean, you're not gonna be able to see it. If you ran your hand across it, you'd feel it, but yeah, but you don't have there's a lot less stuff here than there is here, right? So, pacemakers, they don't put them under the muscle, at least I don't think. And it's, so it's thin here, right? And not a lot of fat here. And so it's much less, I guess, prominent, in the low back.
And these are the leads. I know you can barely see them because they're like the size of angel hair pasta noodles. But they put the 2 leads in the epidural space, and then that's the battery that they connect to under the skin. So this is for the implant.
Yeah, we'll go right back here.
With pacemakers, I don't know if it's still true, but you used to have to be careful with other electrical interference. Is that the case with this?
I think I had one person ask for like a card for the metal detectors, but I have not ever heard. No, I've not had any, or heard of any, or read any kind of interference with other devices.
Can you get MRIs and CT scans and things like that?
Yes. MRI conditional up to 3T,
Full body.
1.5 T.
What happens if you fall on it? I mean, let's just say you're walking and you fall.
Generally nothing. I mean, I don't think it's something that I've had any issue with that happening. Generally, after the permanent one gets implanted, I usually ask my patients to avoid any heavy lifting, bending, or twisting for like 3 to 4 weeks. And I've done these on younger folks that work at GM where there is no light duty, right? And so I'll put them out of work for 6 weeks because they can't go back to work if there's no light duty. But for most patients, it's not an issue. Just taking it easy for a few weeks as far as heavy activity, which involves things that'll untuck your shirt kind of thing. But otherwise, falls, again, I've had patients come to me and say, I fell, and it was not an issue.
Well, we've got Mr. Bennett here, that actually has a spinal cord stimulator and wanted to talk about his story as well. Thank you, Dr. Welker.
Thanks, guys. Thank you guys so much for braving the,
If you wanna come on up. So Dr. Welker actually did his procedure.
He
And
did?
most of you, I feel like, might know Mr.
Make
Bennett.
sure I don't need that.
Okay.
If you can't hear me, you're deaf. Most of you know me. I'm Phil Bennett. I've lived here in Spring Hill 54 years. My wife and I have been married 57 years. That's her sitting right back there. And she's been fussing at me already saying, you don't have any time, you have 3 minutes. You need to shut up, was what she said to me. And that's usually what Marcia says when I speak here at the library. Thank you all for coming out. It's been a stormy night, and we had 36 people, I think, sign up for this. And as you can see, they didn't make it here, but I think it's because of the storms as well as the other people. Yes, let me tell you quickly my story. I have had 16 major surgeries in my life. I've had both knees, both hips, and both shoulders replaced. I've had 3 lower back surgeries, 2 herniated discs with laminectomies and fusions and spinal stenosis surgery. So I was going to pain doctors because my lower back hurt so bad, it was debilitating. Couldn't walk, couldn't stand, couldn't sleep. 2-3 hours at a time in snatches, and it was just, quite frankly, causing depression for me. And so I had gone to 5 different pain doctors. I had the ablations done, the electronic ablations where they put the needles in your back, and didn't help. Now don't get me wrong, the doctor explained to me this might help you 30%, but that'll be the best we can hope for, but it didn't work. All the other pain doctors said, well, we'll give you some morphine, we'll give you oxycodone, we'll give you some Lortabs. And I said, but I don't want drugs. I don't want to be a drug addict. I don't want to have to do this the rest of my life. I use Spring Hill vernacular. I said, it makes me feel yucky. I think you all know what that means. Finally, my family physician referred me to Dr. Welker. I went to Dr. Welker in March of this year, and I'm going to brag on him even though he's standing back there looking at me. I was so impressed for this reason. I went in and told him what I just told you. I've had all these surgeries, I've got pain, I'm debilitated from that pain, but I don't want opioids. That's not the answer for me. If you don't have anything else to offer, then I'll thank you for your time and pay you and go on about my way. He pulled up a stool, sat down in front of me, and spent the next 30 minutes or more or longer explaining to me that I needed the spinal cord stimulator. He got me brochures. He got me a DVD and said, take it home and watch it. He explained about the trial and what it encompassed and the entire procedure. And I was so impressed, even though I was skeptical. Folks, I was very skeptical. How does this work? But I came home, talked to my wife, we read the information, we talked about it, and I called back and scheduled the trial. Went, had the trial done, so simple, so easy. The Boston Scientific people were magnificent. Dr. Welker did a great job. There was no pain involved in it. They don't put you to sleep. Thankfully, they do give you a Valium so you don't care. But it was just so easy. And I wore the stimulator outside my body for the 5 days. Went home. What happens when you reach around and flick a light switch off? What happens? Light goes off, doesn't it? That's the way my pain was. It was like somebody had reached around as soon as I got up and flicked that switch, and I had no pain. None. Not 90%, not 30%. I had 0% pain. After 5 days, I had to go back and have it taken out, and I'll be honest with you, I squeezed out a couple of tears because I didn't want to. I begged them to let me keep it, and they said, no, we have to take it out. This was a trial, it's a test. And I asked Dr. Welker, I said, Dr. Welker, when can I have the permanent one installed? He said, well, it's probably going to be 6 weeks to 2 months. Then I really cried. So I asked them, I said, please, this has been such a wonderful experience for me. I have been pain-free for the first time in 20 years. 20 years of pain. So he said, well, I'm going to take your name, put it on a list. If somebody cancels, which occasionally somebody will, we'll move you up the list. I said, thank you. Came home and just was devastated. I want this thing so bad. 10 days later, I got a phone call. from one of the girls in the office and said, "Hey, Mr. Bennett, we have a lady who has COVID and she was scheduled to have the procedure and can't do it. Do you want to take her place?" I said, "Honey, I'll be there in the next 10 minutes if you need me." She said, "Well, if you can come Monday morning at 6 o'clock, we'll get your device placed in." So I went, had it done again, the simplest procedure ever. There is absolutely no pain with this procedure whatsoever. They were so good, they were so nice. I came home, I went through the recuperation process. My wife made the statement to me, "A man invented this device because it has a remote control." So we were pretty sure that that was the case. It's amazing. It's absolutely amazing. I don't even know how to describe it. Dr. Welker was very patient with me, but he was also very firm. Don't bend over and tie your shoes. If you drop a penny on the floor, don't bend down and pick it up. Because if you do, those leads will move in your back and I'll have to go in and reposition them. So I didn't do anything but sit on the couch for 2 weeks. Went back, had my clamps taken out where they put this thing in, and that was the most uncomfortable part of the test. It was nothing to it, y'all. It's just amazing. Since then, I'm a new person, brand new. It is absolutely life-changing. I don't know how else to say it, but it will. It'll change your life. Honey, you say something.
Amen.
Hallelujah.
But there was some pain when they first put it in.
Oh,
because
sure.
You have to, it's gotta grow in there. So
It
leaning
was
back,
minimal.
you just had to be careful.
It was minimal. Let me tell you what I'm doing now. Now, I had this done in March, and this is July. Now, I go out with a chainsaw, and I cut down trees, and I cut bushes, and I rake, and I trim, and I do around the house, and I fix bird houses, and I set traps for wild animals. And I have my life. I had stopped fishing and stopped hunting, which I have done all my life. Now I feel like I can do that again. It's 90 feet from my back door to my mailbox. Folks, I couldn't go get the mail because I could not make that journey and come back home because I hurt so bad. Now I can trot around. She and I walked not too long ago, 2 miles.
Wow.
2 miles.
Can you bend over?
I can bend over. I can touch my toes. I ain't gonna do it, but I can. But I have no pain. No pain at all in my body. Now here's the good part about this too. With both of my knees having been replaced, I had arthritis in my knees. And so the Boston Scientific people came in, and the girl took her little computer, and I told her, I said, now, I've had TENS unit, for those of you who have had TENS units before, and you can feel them, you can feel that electric impulse or tingling. I told them, I said, I don't want that. I don't want that at all. The girl said, well, we have to do that because we're gonna position this in exactly the position it needs to be. And so they turned the little computer on, and I sat in a chair, and I could feel it kind of buzzing on my back, and they'd move it up, and they'd move it down, and to the left, and to the right, until they finally got it centered exactly on where the pain was in my lower back. And I told them, that's it. That's the spot. That's where it is. She reached over and punched the button, and I'd be dead dumb if it didn't quit hurting. Then they did the same thing with my knees. It tingled, they moved it up and down, left and right, and I told them, you got it, that's where it is. They punched the button, and I don't have any pain in my knees.
Wow.
No. It is absolutely amazing. I don't understand why hospitals and doctors and nurses and medical professionals and anybody else who has this thing don't shout it from the ceiling, from the top of the trees, get on the roof and shout it. folks, it's a relief from people who suffer from chronic pain. So if you or anybody you know suffers from chronic pain, please ask them to ask their personal physician to give a reference to Dr. Welker or some other pain doctor who can do the spinal cord stimulators, because they work, and they work great. I have a lady who goes to church with me, and I told her she has been so debilitating that she could barely walk, could hardly walk. And we had talked about it at church, and when she found out that I had this procedure done, and I told her, I said, you need to get your doctor to get you a reference to Dr. Welker and see to it that he treats you. Well, to make this long story short, she just about 3 weeks ago had her SCF, spinal cord stimulator put in. I talked to her at church Sunday. She said, I'm 95% pain free. I have just a very little residual pain in my back. She's been bent over and walking like this.
Oh, my
At church Sunday, she stood up straight just like I am right now. It's amazing. I don't even know what else to tell you. If you got questions, ask me and I'll try to answer them. If I can't, Dr. Welker's still here, and if he can't, the Boston Scientific people are here. So between all of us, hopefully we can answer your questions. So, shoot.
So
Yes,
I have a
ma'am.
question.
Yes, ma'am.
You made the comment that after you couldn't bend over for 3 weeks. You weren't supposed to bend down for
Right.
3 weeks.
Right.
So you really can't live alone and
Well, you can, it just limits you as to the things that you can do. If I dropped that penny on the floor, I just had to leave it. I didn't pick it up. And if I needed to put my shoes on, I slipped them on without tying them and just walked around with my shoelaces flopping. So there are certain things, yes, that you can't do. You don't need to pick up heavy weights, he'll tell you that. You know, if you got a dishpan full of water, pour it in the sink, don't take it outside and throw it out the window or something.
Well, it was like after hip surgery, you couldn't bend over for 3 weeks or 6 weeks, you know. So I was using a grabber for everything, and I don't know if I could do.
Well, I don't know that you really have to. You're not so limited that you can't do it. It's just that it puts you at risk. You don't want these two metal wires, basically, these leads that go up beside your spine. If they move or they get out of position, he has to go back in and reposition those where they need to be. So you don't want to do that. But I didn't have a problem with it, and I don't think you would.
Did
And
your wife have to do everything